welcome to the Primi Chats. Primi Chats is our weekly educational sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Baquin. I'm a Primi parent and Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led organization that helps families in and after the ICU through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live, please bring your voice to this table, leave your comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this that we can advance, practice, and learn together. So please participate and let us know where you're watching from. And today is, on May 19th, is World Human Milk Donation Day. Human milk donation was created in Brazil in 2004 and is now celebrated worldwide to promote the importance of donating human milk to nonprofit human milk banks. Our guests today are Dr. Belal Alshaikh, who will talk about how human milk helps preemies' gut health, and Jannette Festival, founder of NorthernStar Mothers Milk Bank, who will explain how human milk banks work from donor to recipient. And our first guest of the day is Jannette Festival. She is right here joining us live from Calgary. And in this presentation, she'll provide informative insights into the world of milk banking with a focus on the increasing need and safety protocols required to deliver a safe product to our hospitals. We are going to discuss the benefits of a human milk diet for our most fragile population, safety protocols and regulations involved in milk banking, and the role of milk banks in promoting breast and chest feeding. She's a registered nurse with over 20 years of experience in labor and delivery, postpartum and perinatal education, and an international board certified lactation consultant. She's the founder and CEO of NorthernStar Mothers Milk Bank and has gained extensive experience in providing lactation support and promoting human milk bank. Jannette, thank you so much for joining us here today. I've been trying to have you in this live chat for quite a long time, so I'm so happy that you're joining us in this very important day for the work that you do for our community.
Thank you, Fabiana, and thank you for that wonderful introduction. And I want to give a special thank you to our over 800 donors that have donated milk to Northern Star in the past year. So a big shout out and thank you to make even human milk banking possible.
Absolutely. And I know you have a presentation to share with us, and to all of you watching us live, please do send your questions, your comments, and you're going to address them at the end of her presentation. Jannette, the floor is yours.
Thank you. First of all, I would have to start this presentation with the benefits of human milk. Why do we use it? And first of all, for babies in the hospital, preemie babies especially, there is a lower incidence of neck necroticizing enterocolitis in preterm infants. And just for an example, before we opened, so 2012, 2013, the rate of neck for babies under 33 weeks was about 5%. Today, it's about 2% or a little less. And donor human milk is a large essential piece of the puzzle in solving neck. But there are other pieces we need to put in place besides donor human milk to reduce this terrible disease. Premature milk is higher in protein and minerals, which is important because we need to grow these babies, and they have special needs, different needs than a full-term infant. And the fat in the milk enhances the development of a baby's brain and neurological tissues, and it's easier to digest than formula, and it avoids pathogens and exposure of the intestine lining to cow's milk protein that, of course, we find in formula. And breast milk in the first few days contains higher concentrations of antibodies to help any baby fight infection. Some people refer to it as baby's first vaccination, and but if you're an anti-vaxxer, that's probably not good news. But overall, it's great. So milk banking in North America. So I did start the milk bank, and we opened in 2012. And we don't, I don't make up the rules. I belong to a professional organization called the Human Milk Banking Association of North America, and they set our safety standards which milk banks can operate within. We really are a food facility. We're classified as food, and we have to have the utmost standards to keep that food safe for our babies. We do operate as a nonprofit, so our interests are aligned. We don't have money that we're trying to achieve, or we're trying to increase our margins, that sort of thing. We have annual inspections. I actually am an inspector for milk banks within North America. There's 5 of us that travel around to 31 milk banks. We have access to research of human milk. So there's a lot of researchers associated with milk banks, and they share their research with us oftentimes before it hits publication. And Himbana can act as a liaison between member banks and government agencies. We don't see that as much in Canada. The Himbana is very US focused, and they have a 50 or 40-year history there. I want to start with the safety of the milk and the donor profile. So who donates to a milk bank? So typically it's healthy moms with excess supply. It's bereaved moms, some moms that have lost their baby in utero, they miscarried, their baby unfortunately passed while in the NICU. And also surrogate moms. Oftentimes these surrogate moms will have babies for others, but if there's a distance and her milk can't be accessed, a lot of these moms will go ahead and donate to a milk bank. It's almost like it's the gift that just keeps on giving. Moms must not be taking large amounts of herbs, only because we don't have a lot of studies on it. Over-the-counter medications, a lot of them are allowed, things like plain Tylenol or acetaminophen, that sort of thing you can take while you're donating. Prescription drugs. There's a lot of drugs that can be taken, typically things like insulin, some SSRIs, just medications that are taken every day. If you have a chronic illness, many of those are allowed. Recreational drugs, no. Sometimes a lifestyle comes with that precludes you from being a safe donor to the milk bank. Consuming alcohol on a regular basis. So if a mom has the occasional glass of wine, we ask her to wait 6 hours before she pumps her milk for donation. So a lot of moms will pump their milk first, and then they'll have their drink. And by the time they're ready to pump again, the alcohol is out of their system. We ask that babies are under 1 year of age while they're donating. And the reason for that is sometimes we don't have room in our freezers. If a mom really wants to donate, her milk at 1 year of age is perfectly good. And sometimes we'll let them go past that to 15 months. And truly, we do allow up to a year and a half. But we don't have a lot of moms who do that. So the screening of our donors is a multi-step process. So we first start, a mom will contact us over the phone. She'll fill out a form online and tell us when we can call her. And then we go through, it's almost like a pre-screening. So we ask lifestyle questions. Is she on any medications? And we let her know the commitment. So we like to ask for 150 ounces or 4.5 liters within the first year of donating her milk. And many moms, a lot of moms already have a freezer full of milk, so it's not an issue. Following that, we will, if she can commit to those, then we will email her a donor questionnaire. It's about 35 questions. It sounds like a lot, but it's not. They're check boxes. and detailed instructions on sterilizing and collecting her milk. We can have a problem, an issue with bacillus, and it shows up typically if her equipment, her pumping equipment is not sterilized properly. She will need to go to her healthcare provider, which needs to be a physician, midwife, or nurse practitioner, to verify the health of her health, and her physician needs to be sign off on her. And it's not an involved process. It's typically answering 3 questions with a tick box and a signature. She also has to have a blood rec form we will actually send that to her. And so we test for 5 different blood tests, very similar to the blood banks. So it's the same 5 tests: the HIV, the hepatitis, Hep C, HTLV, and syphilis. So once we get back all that information and it looks like she meets all the criteria, then she becomes a donor, and we can take milk going back 6 months in time, and of course any milk going forward. Again, once the mom becomes a donor, it's not like that's thanks. You can donate your milk, because it's over a long period of time. It can be for up to a year. We have to have regular check-ins. So we do have really great trained staff that will call the mom every 6 to 8 weeks just to check in and to make sure, is everybody healthy? Are you healthy? Have you been on any medications? Are you paying attention to the protocols, and just answer any questions that she may have. So again, it's a little bit different than donating blood, where it's not a one point in time. It's over a period of time. If a milk donation comes in, before we log it in to use it, staff will call and again just verify the questions about medications and alcohol. Sometimes moms forget. They're busy, they're tired, so it's just a little reminder. And also we check in to see that has she had any vaccinations. Temporary deferrals of donating milk. So if a mom at birth had a blood transfusion, there is a 4-month deferral before she can donate her milk. So she can pump and store at home, and then she'll have her blood test, that the 5 that we give her, the blood screening. And if it comes back and she's fine, then we can take all the milk going back. Breast infections, if she's had mastitis or yeast infections, we ask her to call in, and we let the donors know the deferral period, and we also need to know if she's on any medications. Temporary use of medications, if a mom has a UTI or some sort of lung infection and she's on antibiotics, she'll call in, she'll let us know the date she started feeling sick, the date she started the medications, and we'll tell her deferral period. It's typically like the entire time she's taking the medication she can't donate, plus a deferral period after, which is typically 5 times the half-life of that medications, or of the medication, but sometimes it's longer. If she's had a live vaccination, so if she's had yellow fever, smallpox, which we really don't have in Canada, and if she's had a fever or a tattoo, there's a 3-month deferral. Tattoos are a funny thing. Sometimes they're safe, sometimes they're not, and we've seen that in Calgary. Probably about 10 years ago, there was, I guess not a recall on people who had tattoos, but there were certain parlors that had actually had contaminated needles, so those people had to be contacted and to go under treatment. So all of this, again, it's in anticipation. It's a what if this happened. I'll go now to the safety of the milk in the lab. And I wanted to start with this, and typically when we pool our milk, we will pool 3 to 5 moms together. And I like this diagram because it explains why. This is milk from 3 different moms. The milk on your left, I don't know if you can see the fat layer, but there's a nice fat layer there. The milk in the middle is more mature milk. and I just lost my, oh, there I am. And the milk on the right is colostrum and preterm milk from a premature baby. The values that we read on this milk, the fat and the protein, are quite different. And so we do analyze them. We look at the milk and we pool the months together. The reason we pool, one is for safety reasons, and the other one is to get a nice, it's almost a little bit like engineering. We can actually pool them up together to get certain values to send to our hospitals. Like I mentioned, we have a Delta lactoscope. It's a wonderful machine, and I love it. And it takes about 10 mils per sample. So every time it reads a sample, we get 3 different readings. Just to make sure the machine is within range. And this is a picture of Michelle, and she's analyzing some milk, and you can see the values pulled up on the screen. And basically, we like to concentrate on the fat and the protein. As far as the carbohydrates, the HMOs in the milk kind of mess up with the carbohydrates. They increase the reading, and of course, babies don't digest HMOs, so it can skew the readings. Not a whole lot, but some. Once the milk is analyzed and we pool it, there's a picture here of Sasha, and she's filling the bottles. So we fill them to exactly 120 mils, and that is very important for reasons following up on the next slide. So all the milk is bottled before it goes into the pasteurizer. So once it's heat sealed, it's never opened again until it gets to the hospital. We do use Holder pasteurization, and this is a picture of Chris, and this milk has already gone through the cycle, so you can, when it comes out, it's about 4 degrees. Holder pasteurization, what it does, it heats the milk to 62.5 degrees Celsius for 30 minutes, and then that destroys any pathogens that may be in the milk and are harmful to baby. And that one bottle there with the purple lid is actually it's where a temperature probe goes in. So we want to make sure that the temperature of the milk actually reaches 62.5 and not just the circulating water back. And we pull that out, and it ends up going into the freezer shortly after. Once the bottles come out of the pasteurizer, the levels are checked. Because it's heated to 62.5 degrees Celsius and then it's quickly cooled to 4 degrees, it can create a vacuum. So we just want to make sure that those bottles have not taken on any water. If they did, we know the seal's broken. So the seals, the levels in the seals are checked after to make sure that the bottle remains intact. So how do we decide where the milk goes to? So we do have a policy on triaging the milk. So the milk will always go to our level 3 hospitals first. So it's basically why we're here. And following that, if there's milk left over, the level 2 hospitals, and babies who maybe are in for observation or had a shocky birth, if the hospital wishes to, they can supplement those babies if mom's milk isn't available. And also ill infants in the community. And then after that, well infants in the community. And that's mainly used for bridging of milk and then also research. So points 3 and 4, the infants in the community, they do require a prescription after 10 bottles. If it's just to bridge the babies, we don't need a prescription for that, but anything after, we like to know because that baby will be put in this triage, and if they're not, and we had to cut back on the milk, we just want to make sure that that infant is protected. And since we've been open for going on 12 years, we've never run out of milk. A couple times years ago we came close, but we were able to meet all the needs of the hospitals. This is our bereavement wall. So we do receive donations from a lot of moms who lose their babies. and choose to donate to the milk bank. Through research, we know that those moms, when they donate to the milk bank, it's very healing for them. It gives them routine, which is good if you're going through the grieving process. It gives them purpose, and it gives them a reason to get up in the morning, and it leaves a wonderful legacy for their baby. So this is a Van Gogh. It's supposed to represent a Van Gogh Starry Night, and each one of these stars is a baby that's passed, and the mom has donated milk to the milk bank. It actually wraps around another wall, so it's a beautiful tribute, and it's a legacy for these parents. These parents go home, and oftentimes nobody's even met their baby, but this is one place where their baby is recognized. What else does the milk bank do? Sorry, my slides, I guess, shifted a little bit when I transferred them over. So we're not just a milk bank, we do other things as well too. So this slide is a little bit old. We've been open in pharmacies for quite a while. So we do have 3 pharmacies in Calgary that dispense milk for us. So if you do get discharged from the hospital and your milk supply is still not quite there, then you can go to the hospital and to the pharmacy and purchase donor milk. This has been a really great help for us in the milk bank and for moms in the community. And why we chose the pharmacies versus a grocery store or whatever. The pharmacies, so for the first 10 bottles, you do not require a prescription, but also they're open on weekends and evenings when we're not. So the mom or the parents or caregivers can quickly access that milk when needed. Pharmacies are great. They keep wonderful records. They have dedicated freezers and with all sorts of temperature guards on them. And we're more than happy to help us out. What we also do is we do breastfeeding education and equity. So we have something that we've just started, and we're having our first class next week. It's called the B program, and it's very similar. 3 of us went out to Kitchener, Ontario, and we observed the Breastfeeding Buddies program that they have there that's been running for 20 years. And it's a peer-to-peer breastfeeding support program. And we know through research that it's effective and cost-effective. So what we do is we're taking 25 moms in the community from target populations. So typically they're underserved populations. They could be new to Canada. They could be parents who don't know how to navigate the healthcare system. And then what we do is we give these peer mentors an 18-hour breastfeeding course that's recognized by the WHO, and on how to be a peer mentor. So how to be a social support for that mom, how to help her with minor issues that may come up. So what we want to do is prevent that mom from having to access the healthcare system, and also provide that mom with somebody that may need their help, that has had a baby, has breastfed, and can help her. So the mentors and the mentees, they always meet in public spaces or at the milk bank. And again, we target underserved populations. And our first class is being offered next week. So it's 3 days in a hotel with babysitting. So a lot of the moms are looking forward to that. And if it is successful, then we're going to look at fundraising to build on this program and probably offer it every 6 months. And so what happens if the mom does run into trouble, she can call the milk bank, and Chelsea, the lady, my assistant, who's sort of managing this project, she will line them up with a mentee, and support could look like a text. It could be a Zoom call, or it could be in person. And I believe Winnipeg has started a program a few months ago, very similar to this in the Breastfeeding Buddies. So it would be really nice to see this across Canada. As we all know, there's just not enough support out there. So milk banking in the community. So milk banks are positioned to reach out and support breastfeeding moms in the community. That's who we work with, is breastfeeding moms. We do provide support here in the milk bank. I am an IBCLC, as Fabiana mentioned, and so we do support our donors and others who are not donors as well too. They can give us a call. And we know that early intervention can prevent moms from ceasing their breastfeeding journey. And again, I just want to say, without a breastfeeding community, there is no milk banking. So supporting this community and being there for them is extremely important. And I think this is the end of our presentation. Oh, no, sorry, one more slide. So this is just a sampling of our donors. So as I mentioned, our donors are surrogates. They have multiples. The picture on the bottom, you can't see, there's 2 babies there, but on the right, there's the third. So this mom had triplets, plus she has a newborn. So the triplets came first. So her body had a memory like, oh, I got to produce milk and lots of it. So every 2 weeks, she would come to us. She would back up the van in front of the milk bank, and we would all run out and take the milk off her hands, and then she would drive away. So it was really wonderful what she did for other babies. And that is my slide. So if there's any questions, I will attempt to answer them.
I am mute, so now you can hear me. After 3 years, we still forget to unmute ourselves. But thank you so much for this presentation. It's so great to see the work that you are doing and how many people actually engage in the community to donate milk. So it is pretty great. So thank you so much for shining a light and educate us on human milk and the importance of donation, especially today that is the World Donation Day. So my first question to you is, only families, at this point in Canada, only families in hospitals have access to donor milk? Because sometimes families in the community, they run out of milk, they can't pump anymore, or their baby's not getting breast milk, and they want to access. Can they have access to the milk bank?
They do have access, Fabiana. Again, it's triage to sick babies in the community first. But I would safely say right now we just about, I wouldn't say just about anybody, but most people can access some volume of milk.
No, that is great. So for all the information, I just connect with the milk bank and you're going to guide those families, I believe. Is that correct?
Yes, and they can just give us a call, and we ship via FedEx overnight if they're out of the province.
Okay, so Dr. Alshaikh, who is our next guest, sent us a question. Great talk. Is there a difference in milk content values between MIRIs and the current machine lactoscopy use in terms of reliability?
So I did do some research with a couple other researchers on the different machines, and probably the difference is the MIRIS uses near infrared, and our machine is a wider spectrum. I think for hospital use, the MIRIS is probably the way to go because it uses a very small volume of milk, and you just have to be careful with how you prepare the sample because you use such a small volume. User error could come into effect if you have a very small volume and it's not prepared correctly or it's not put into the cell correctly. So they're good. They're both good. If we didn't have the machine we have here, we would probably use the MIRIS.
Okay, so one more question for families who want to donate. Do they need to live near the milk bank, or they can send the milk from different locations?
We send the milk all across Canada.
They can send from across Canada?
Oh, if they become a donor, yes, they can. We do cover all of Canada. So typically we don't take donors where there is a milk bank within the province. So BC and Ontario, we don't take donors because they have their own milk bank that they need to support. But all other areas we do. We haven't been taking Nova Scotia just because they get their milk from Ontario. So we let them take those donors.
Okay. We have a comment here from Bethany. Hi, Bethany. Thank you so much for joining us. I'm watching live from Liverpool, Nova Scotia with my 23-week preemie, who, with the help of a donor, was giving breast milk in the IWK for our 128-day stay. So thank you, donors. This is such a beautiful message that I'm sure
Yes.
you have from a lot of parents that come to you, come to the bank through the hospitals to thank the donors. So do you want to send a message to all the donors who keep
Uh,
the bank alive and keep supporting our babies thrive?
our donors, they move mountains for us. They're the ones that create these miracles and help to keep these babies alive. So a big shout out, and what a great day to say thank you to them during this World Recognition Day. So thank you.
So for everyone interested in your peer-to-peer, your B program, how we can be involved in that? Because it's such a great idea and a great program that I'm really looking forward to seeing the unrolling of this program in Canada.
I know it is sometimes I think I don't know what we unleashed. We had a high enrollment. We have a lot of people from the Immigrant Society as well too, who want to help moms within their own community. Breastfeeding looks different for everybody. We come from different cultures, backgrounds, and I think it's wonderful that we can train moms in that culture and background to take that information back to their own community. So we do have, you can follow us on Facebook and it's called the Breastfeeding Education and Equity Program. And people are calling it the BEEP program, and it's actually the BEEP program. But, and on Instagram as well too. There is, so we've just started. We've got some research to do after the first group, but they can just give us a call or contact us through social media, and we can fill them in.
Wow, that's wonderful. So, Jannette, thank you so much for joining our live session today. I'm so grateful that you are here sharing your expertise, your experience, and really encourage people to donate. It is such a great day, and I'm very happy that you are here with us for this celebration day.
Thank you, Fabiana, and thank you for this opportunity.
Thank you. And our next guest today is going to talk about preemie's digestive system and feeding challenges, how human milk helps promote preemie's gut health, and the Canadian approach to prevent gut illness in preterm infants. And he's right here, join me live from Calgary. Dr. Belal Alshaikh, who is a staff neonatologist and medical director of the NICU at South Health Campus in Calgary, and a clinical associate professor at the University of Calgary. Dr. Alshaikh co-chairs the Canadian Neonatal Gut Health of EPIC and is a founder of the Society of the Neonatal Nutrition, Gut and Growth. Dr. Alshaikh, thank you so much for joining us here today. I'm very excited about your talk because you are on a mission in Canada, and I'm so grateful to have you here on this important day. Okay, let me unmute you. Okay, here you go.
Thank you, Fabiana. It's a great pleasure to be on Preemie Chat again. I really love it. And I am today is one of the best day to celebrate like the human milk and the donor human milk as well. So it's good to go like over the challenges our preterm babies or preemies they face during their stay in the NICU, especially from their gut point of view.
Absolutely. And all of you watching us live, please do send your comments or questions, and we're going to talk to Dr. Alshaikh after his presentation.
Yeah. So as adult, we always talk about our gut feeling, but we never think about how the preterm infants gut do or feel during their stay in the ICU. And here we go. I am going to speak about the gut system in preterm infants, just to give an overview and some understanding of the development of the intestine or the gut, and also like what we expect from this gut to do for those preterm infants. So as I said, I'm going to go over the digestive system for preterm baby. And also, secondly, and I will talk about the how human milk promote the preemie's gut health, basically, and also will touch base on the Canadian approach to prevent gut illness in preterm infants. So starting with the digestive system, So when the baby is born, or the preterm baby in particular, they born in the third phase of the development of the gut. So here on the left, you see like the phases of the development of the gut system in a human, and it has 5 stages or 5 phases. And usually, preterm babies born before 37 weeks, they have not yet completed the third phase, which is where the differentiation of the cells and more cells start to come on board and function in their gut. And if we look on the right side, we see like those villi, how small they are when the baby is born preterm, and also the crypt, which is the one down here, and compared to babies born at term when they have like longer villi and deepest, also deeper crypts. So the surface usually is larger for term to absorb nutrient for term infants. In general, when we look at the intestine for even the adult, there is strong correlation between the height or the length of the person and the length of the bowel. So here on the left hand, you see the body length in the y-axis and the bowel length on the on the y-axis, and the body length on the x-axis. So if a baby born at the term, usually around 40 weeks, their bowel length is around, their length, height or length is around 50 centimeter, or anywhere between like 50 to 52 centimeter. And this will put them on the 200 centimeter length for their intestine. While a baby born usually around the 24 to 32 weeks, their body length is around 40 centimeter, anywhere between 40 to 45. Sometimes even less. And you see their bowel length here is around 100 centimeter, which is almost half what the babies at term have. It's not only the length of the bowel. If you look at the right side, also the diameter of the bowel and the cylinder surface is way bigger in term baby compared to preterm infants. Not only that, but also if you look at the neurodevelopment or the nerves of development, the nerve system development of the gut, it's very immature in preterm babies born anywhere between like 25 to 30 weeks. And this neural system in the gut, what helps the bowel movement. So if you have a baby with poor, disorganized bowel movement, usually they accumulate a lot of gas in the bowel, and also the milk is not well digested as well. But also they don't pass stool that frequent. If anyone like noticed that, many of those babies they require glycerin to pass stool. But this disorganized bowel movement start to mature when the baby around 30 week, and then after that start more and more to be more mature and more organized. How to promote preterm infants' gut health? Human milk is the best actually agent to help the gut grow. And we always recommend the mother's own milk when available, but when we don't have mother's own milk, the donor human milk will be like the second option. And we will talk about that later on as well. But what Jannette presented is very critical, that donor human milk is very important for preterm baby when the mother's own milk is not available. And when we think about the human milk in general, we think usually it's the macronutrient and micronutrient that help the baby grow. These macronutrients include like carbohydrate, fat, protein, the micronutrient like vitamins, and also trace element. But the milk provide way more benefit than that. So here on the priming of the gut, the human milk help the growth of the surface of the gut, and the growth of the intestine in general, like in the length, in the cylinder size. And on the right here, you see like the importance of human milk to promote the immune system in the gut. So with promotion of the immune system, like with lactoferrin and immunoglobulin, that will help fighting a disease like NIC and also fighting infection and sepsis. It's not only like during the neonatal period or shortly after birth, but human milk has a huge impact on later on in life, like what happened to those babies, especially preterm babies in life. And here we look at the different effect between the formula milk and the mother's milk or human milk on the microbes in the gut, what we call the microbiome or the colonized bacteria, the bacteria that colonized the gut, which start right after birth and continue to develop over the time until the baby even 5 to 10 years and later on as well. But if we have like a baby on formula, there is a risk for necrotizing enterocolitis when the gut start to get inflamed, and also a part of it might die as well. Also, there is a risk of increased obesity and also risk of atopy, like allergy in the skin and also the lungs later on in life. But this is like not only limited to the, especially the obesity and atopy for preterm infants, but also for term infants. The availability of mothers on milk, and what we know so far that not all mothers in the NICU will be able to produce milk for different reasons. Uh, Many of those related to hair like sickness and the preterm birth and many other factors as well that contributed to the birth of the baby. So, but what we know that preterm babies born like as early as 23 or 26 week, the rate of breast milk feeding at discharge is around 38%. It goes up to only 50% at 30 to 31 weeks. So it's still low. So and that will put here the need for donor human milk to support those babies, and also to relieve the pressure sometimes on the mothers who they are not able to produce their mother's own milk. The best practices we always talk about for education, how to improve the mother's own milk production in the NICU. We talk about starting early for pumping after birth, also hands-on pumping, and there are many studies also about using the pump right away instead of the hands. Also doing some education about the milk itself, how important, and that every drop counts. So we encourage mothers to produce even a small amount of milk, which is what we expect in the first few days of life. And also we talk about the golden drops, because those are really like golden stuff coming to the baby's gut. And we talk also about the kangaroo care that will help also improving the production of the milk. In one project a few years ago, this is just to show what we have done in Calgary. And this is project actually led by one of the lactation consultants in Calgary and also one of the QI nurses. Those actually the two ones who led this project. The project aimed to improve the production of mothers on milk by doing lots of education right after the birth of those babies, and around the time of birth if possible, within 12 hours. And everyone, like not only the lactation consultant, but it was also like from nursing staff that working in the NICU. They start talking about with the mom from the beginning how important is to start pumping, and also to support them if they need any help. And with that one, we managed to increase the human milk feeding at discharge from around 82, 83% to almost 90%. And that itself was enough actually to decrease the risk of NIC from around 8.5 to around 5%. This study actually, like this project, was in 2009 to 2012. This is before having the donor human milk bank in Calgary. We'll switch the gear now to the Canadian approach to prevent gut illness, in particularly the necrotizing enterocolitis. First, what's neck? Neck, when the bowel, as I said before, start to get inflamed, and part of the gut might also die. So some babies even need surgery for that. So it's a big disease, and most of those babies, they are doing good on full feed and feeding well, and then out of sudden something happened to their abdomen, and with X-ray, there's signs that there are necrotizing enterocolitis, and those babies, they need very close support. The mortality rate of those babies is up to 30, so 1 out of 3 to 4 might die because of neck, if they develop a neck. And also, like the length of stay in the hospital, it can be up by 2 months if they needed surgery, and there's always some effect on the brain in many of those babies. So if we compare like neck versus healthy or babies who develop neck versus those without neck, what we know that neck is usually a disease of prematurity. So preterm birth is the highest risk for neck. And also, if there is, as you see here, no breastfeeding or no breast milk feeding or human milk. And also, there are other factors contributing to that. For example, if there is prolonged use of antibiotic for those babies, we know like antibiotic can save lives of those babies because their immune system is poor. But if this antibiotic is very prolonged, it might affect their microbes in the gut. So how to prevent neck? We put the target to decrease neck to less than 2%, as you see here in the middle of this graph. And there are many factors because neck is multifactorial disease. So we need to have like multi-pronged approach for the neck. And we classified also the evidence as you see here. So when we have like strong evidence that this will help, we have like the 4 plus cycles here or circles here, and the evidence go down if there's like just 1 or 2 circles. So one, if you can see here, I'm starting with the first part here. It's the internal feeding, and on the top you see the most strong evidence for prevention of neck is the feeding human milk. So feeding a human milk, whether mother's own milk or donor human milk, it will decrease the risk of necrotizing enterocolitis by almost 1/4 to almost half times. There are other factors also. We use like feeding within a standardized table. And also we use also the human milk to do the oral immune therapy by putting just small drops on the chicks, inside the chicks, just to help the production of some immunoglobulin, and that itself showed to help the prevention of neck. But you see the evidence is very strong for feeding human milk, and to less extent for the other factors related to also feeding milk. There are other factors here on, you see we are talking here about the colonization of intestine by the what we call the commensal bacteria or the friendly bacteria, and this including the probiotic, also avoiding like some drugs that can suppress the friendly bacteria in the gut. Also, we like to avoid anemia as well, which is very important for those babies. And also, we commonly talk about how to treat the ductus arteriosus and how to improve the perfusion or the blood supply to the intestine, which is very important for those small babies. Again, we put the driver diagram how to prevent necrotizing enterocolitis in Canada. And on the top of this, it comes as the human milk and mother's own milk. So you always see like the human milk, and especially mother's own milk, is very critical to prevent necrotizing enterocolitis. When mother's own milk is not available, the donor human milk will also like help a lot. And it's always a team effort how to prevent necrotizing enterocolitis in the neonatal intensive care units. So you see this table coming from left to right, but it starts like before delivery, but you see again like the breastfeeding discussion start even before delivery if possible, if there is time, and we expect like the preterm birth. And start also in the first week of life. It's very important to talk about it. And this you see like the teamwork start with the midwives, the nurses in the labor and delivery, lactation consultant, obstetric team, and also neonatal team if possible. Also after birth, the neonatal team and the lactation consultant will play a crucial role for that. Here is like the example we have for the necrotizing enterocolitis, what happened with the rate of NIC in our institution. And on the left side, you see like the rate of NIC. NIC can happen, as we said, around 5%, and sometimes it goes up to 9%, depends on the unit. And we were usually around the 5%. But by introducing like reinforcement of the use of human milk and other factor, we managed to drop or decrease the rate to around 2%. Our aim was to keep it less than 2%, but you see it like hovering around 2%. We still have like work to do, but it's a good actually progress on the field of prevention of necrotizing enterocolitis. And here I will stop, and thank you for listening. And I am ready for questions.
Dr. Sheikh, thank you so much for your presentation. I love your mission of a neck-free Canada. When I heard that in February at EPIC conference, you were all the parents at the table were excited to see a neck-free Canada. So my first question to you is, how are we doing the prevention of neck in Canada compared to other high-income countries? Because we know Japan has almost no neck. So where are you on that comparison with other countries? Are we on the right track?
I think we are on the right track. I think we still have like some work to do, but we are on the right track. The fact that in many institutions in Canada, actually, they managed to decrease the rate of neck to less than 2%. It's very promising, but I think there is still lots of work to do. Definitely, and most of this work actually to support the human milk, because by doing that itself, it might drop the rate of neck by almost close to 50%.
Wow, which is incredible. So on your study, because today is a day of donation of human milk, so we're going to go back to that. So when you talk about your project that was done prior to the milk banks, 2009 or 10, I don't recall the dates exactly. You talk about, back then you reduced 5% in neck, and now with all these banks available and more mothers donating banks, do you see in the future a bigger amount of babies, I guess, receiving human milk human milk from donors, from the milk banks?
Yeah. So the mother's own milk actually is the first one to go, because for donor human milk there are lots of processes go with the milk, and one of them the pasteurization. We know the mother's own milk has the bacteria that coming from the friendly bacteria coming from the moms, so that's very, very important. And the other factor, there are immune factors in the mother's own milk that can help the gut of the baby. So basically, we would like always to encourage the mother's own milk first. But if that's not available, then the donor human milk will come like next, basically. But I see lots of rules for donor human milk in the personalized medicine. and personalized nutrition actually, because as the technology is evolving, there are lots of lacto engineering can goes actually to the donor human milk, and that will help with providing like fortification, special fortification for babies, and also might improve the donor human milk itself as well with other factors. So there are lots of research and work to be done, but both of them, the donor human milk will help always when the mother's own milk is not available. There are other factors going on now, and Jannette probably is helping us actually in our NICU and in other NICU across the country by providing like what we call high caloric and high like concentrated donor milk. We know like the donor milk in general is lower with protein and sometimes fat. So, but there are mothers who produce actually milk with high fat and high calorie and high protein. So reserving this milk to preterm infants might be the way to go actually in the future. And we started doing that for our babies in here in Calgary, and also many other NICUs when the high caloric milk is available, they start using it. So that's like kind of advancement in the field of donor human milk. And there are many other personalized like things we can be done in the future.
That is incredible. And there's so much research coming from Calgary, because I know Mary Lee Brockway is also doing some research on this
Right.
personalized milk, and it is incredible what is coming. So Jannette talked a lot about the safety of donor human milk, and go to so many processes, pasteurization, and you are the bedside with the parent. Is there ever any concern? Do parents are concerned about the safety of the donor human milk, or they know Canada is very precise with safety and the processes that involved in that?
Actually, from my conversation with many parents, and also like from the whole team conversation, uh, we don't see like any concern about the donor human milk from kind of infection wise and other things. So, but there are like cultures who don't like to use the donor human milk for different reason, because maybe they don't know like the mother is producing the milk, all this. But in general, about the safety or regarding the safety, there is not much concern when we discuss that with the parents, because they know like these mothers are tested, and also the milk is pasteurized. So it's kind of safer even than the formula and other things. So way safer than other factors. So we don't see that like coming from the parents. What we see a little bit of hesitancy sometime, because they don't know the mother is producing the milk, and this might be like for some cultures there might need some work to be done on the donor human milk banks, for example, because if some mothers want to know like the mother is producing the milk, or they want this milk of just one or two mothers, they don't want like to pull all this milk. So this maybe like can be discussed on the milk bank levels, and see if there is any approach to help those families who culturally or from religion point of view, they don't want to use it. Although like most religions and cultures, they support actually using donor human milk, but some families they don't want to use it for that reason. But I think there is a rule in the future for milk bank, maybe to create a kind of specific donor human milk that they can tell the parents about that milk coming from which mother, and assure them that this is going to help their baby.
Wow, that is such an important topic that you brought it up, and I'm sure. Let's see if Jannette is here. She wants to make a comment on that. I'm going to bring her without planning. I think this is we have to bring for this question, because I think it's such an important topic. We are in Canada. There's so much diversity, so many different cultures, religions, and beliefs, and this is something that we also heard from families before. So, is your bank addressing these cultural issues on, or how are you dealing with this?
Well, there's for us, our hands are a little bit tied because of privacy issues. And I'm sure there may be a workaround, but it would involve parents knowing exactly what will be done with that information, their identification. I just wonder. I know there's a worry about kinship with some cultures, and will that infant who received that mom's milk, if her infant and their infant meet, what is the consequences of that? So I don't know if giving the information or keeping the information, stored. So if they were to ever marry or whatever, that could at least be a check with a yes or a no. I don't know. This is thanks for that, Bilal.
It's just a brainstorming, basically, because I think
we've thought about it before, right? Like we thought, gosh, like how can we do that? And I would say probably most donors would not want their information released. But maybe the milk bank keeping the information and having like a bank of information. And if there ever needed to be a check without giving that person's name, just a simple yes or no could be a workaround.
Wow. Yeah, it is a very interesting topic for sure, and something that probably will show up more and more. Who knows?
Maybe
But
in the near future.
Yeah, but I really want to thank you both for this amazing session today. I always learn so much, and it's so great to see the amazing work that you are all doing here, really to help our families and our babies really thrive in the world. We have a rough start with our babies, but it's so inspiring to me as a preemie parent and running a parent organization to see how much work is being going behind the scenes that we don't particularly see, just to make those outcomes better for our families and the future of Canada, really, because they are our future. So thank you so much for being here today, and I hope I have you again in the near future.
Thank you.
Thank you, Fabiana. That was great. Thank you, Jannette. Yeah, I loved your presentation.
Okay, thank you both.
Thank you.
Bye-bye.
Bye.